All right, we are back for the Thursday review. We've got 6 short studies on the docket, so let's knock them out. First one, spinal posture, mobility, and muscle endurance in women with tension type headaches. This one's a case-controlled study. They really just found that, like a lot of other conditions, it might correlate with muscle endurance and genetic. Other conditions that I'm referencing are going to be like low back endurance, low back pain, and there's typically a it's not always linear, but there seems to be a direct relationship with your body's capacity and the condition you're suffering from. And then it really boils down to the chicken and the egg discussion of what came first and what we should do about it. Now, for me, in my personal opinion, the second part matters more than the first. So, chicken and the egg, not quite as important because no matter how it came about, we're dealing with it now. So, what can we do to either set ourselves up for success in the future to potentially prevent this if you haven't suffered from this? Or what are some things that we can do since this seems to be a correlation with multiple conditions that the body suffers from? So, really, it's about building the body's capacity from a whole person's perspective, but specifically taking the condition you're trying to work on or prevent in mind. So in this case, we've got tension type headaches was correlated with reduced ability for the neck to maintain muscle endurance in certain holding positions. So there is a cause for thinking about, I'm going to use quotes here. So if anybody's not watching the video, you have a weak neck, and I'm using quotes because again, what defines weak? But if you have a reduced ability or capacity to hold or sustain your neck posture, you may suffer more tension type headaches. Who knew, right? Um, they also correlated general mobility, but again, not quite as concerned about that and having a talking point about that. But you basically have to build your body's reserves so that should something come its way, it has more resources, more gas in the tank to work around that issue so that you don't have any or as many symptoms as somebody who doesn't have that capacity. Next up, the role of musculoskeletal ultrasound in detecting cluneal nerve entrapment. This one isn't so much about the fascination that you can or should even diagnose cluneal nerve entrapment via ultrasound. The condition that it can cause is something called Green syndrome, which, if we want to think about it, that can almost be considered a sciatica of the back because a lot of the symptoms will present the same and a lot of treatment will be the same. It's just a matter of what specific area are you targeting and how. So with this one, we can think of where your bottom part of your mid back, the bottom part of the rib area, is meeting the upper part of the low back. There is thicker fascial tissue. And what happens is your body has to have nerves essentially everywhere and anywhere that you want to do something or feel something, right? So yes, it may not be as big as that, sciatic nerve that we're discussing about, or mentioned before, but these cluneal nerves come down from about that region, and they have to go through and or around and in between tissues to get to different parts of your back near the surface by your skin. So if we have skin, connective tissue, deeper connective tissue, and in between here we'll have that we'll have fascia components in these layers, and then we have muscle tissue. These nerves have to go through, so nerves, layer of tissue, they have to go through and then get to their endpoint, right? Well, along that way, this fascial tissue may be irritated, tight, something is causing it to constrict the cluneal nerves, which leads to main syndrome, aka sciatica of the back, where you'll have vague, broad pain in your flank on either side, wrapping around your glute region. It may also creep around to the top front part of your thigh, and it can lead to typically unilateral, so one-sided genital pain of some sort. So, um, a lot of the times when I'm treating men with this condition, kind of in that hushed tone, like, "Yeah, I have this back pain, and, doc, around the time this started, my left testicle has been aching. Is that something to be concerned about?" And again, depending on our risk factors and who we're treating, if we think it's Mean syndrome, we'll tell them, "No, it's not something to be concerned about." If we think it's 2 separate things, then we'll tell them to follow up with their urologist. But, in women, it can also then be that discussion of, yeah, they have that thigh pain, and it may turn into one-sided labial pain. But this study wanted to do a couple of things as far as showing what ultrasound can do, and it's not that important to, have a hard line diagnosis where you take a separate appointment, go pay for somebody to find an ultrasound and say, "Yep, you have it or don't." This one's fairly straightforward. It's something that you can diagnose uh, with a decent exam. And what I wanted to take the time to talk about is that this is just more reassuring from a patient standpoint that just because you have pain that is related to a nerve does not mean that you have nerve damage, because this constriction does not cause any adverse events or long-standing nerve damage. So it's one of those things where if you address it, no harm, no foul. It's just like you pinched something. Um, so I like that fact that, yes, we took an ultrasound diagnostic study. It's cool that they're looking into this sort of things and that they're finding that correlation that we can discuss about. But it's also cool to then show that um, these changes aren't really damaging the nerve and they're not just nerve specific. So I'm going to jump to their conclusion. Ultrasound detected fascial alterations and tendon changes acted as a reliable surrogate marker for that cluneal nerve entrapment and correlates strongly with actual pain severity. The absence of the correlation with neuropathic nerve pain suggests a predominantly muscular biomechanical mechanism rather than direct nerve damage. Awesome. We get to be a little bit calmer when we're dealing with this, because sometimes these symptoms, the way that they're described, the way that people go through them, it can be very concerning. Give me a sec. Apparently, I have to reset my eating parameters. Anyway, back to the study. Um, just lost my train of thought. Oh yeah, it really just helps us reassure the patient that they're in the right place for the right reason, and that we can work with them despite some of these potentially concerning symptoms. And as long as we're on the right path, they should see resolution, even though they may be feeling like it's nerve pain, which can be scary. This nerve pain can affect the genital region. I don't care what condition it is, that could be a cause for concern, a high cause for concern that people may want to just jump ahead to advanced interventions. Uh, and it really just helps us to add that education piece that, hey, the nerves may be quote unquote worked off, but they're not damaged. This is mainly a musculo and connective tissue issue. So let's address it with the best evidence based approach that we know about that's fit to you to take care of this condition, and you'll be right as rain in a reasonable time. So it needs study, is what I'm trying to say. Bum, 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 bum. Short one, rheumatoid arthritis is now being considered an independent stroke factor risk. So, like a lot of our other um, factors, like modifiable factors, lifestyle factors. So, if you're a smoker, you're higher risk for pretty much all cause mortality versus somebody who isn't. You can modify that. Um, if you have certain family genetics, you're predisposed to certain conditions just through the family tree. This now, rheumatoid arthritis, if you have it, the process of rheumatism seems to predispose people to developing strokes. So if you develop it or are at risk, or if your family is somebody at risk, it's one of those things to really just take control of as many things, as many aspects of your health as possible now, because you are potentially at increased risk for other conditions. And this one's a big, scary one in the sense that it hits hard, it hits fast, and it is a cause of legitimate concern because it's life threatening. So if you have it, do everything you can to stack the deck in your favor, to eliminate as many of the modifiable risks as you have and uh, know the clinical signs for stroke just so that you can catch it early, you can get in and get it managed to the best of the ability at the time. Again, this isn't to scare anybody, it's just a state of fact of life. Uh, this article found out that, or sorry, this meta analysis demonstrated that rheumatoid arthritis is associated with an increased risk of stroke as its own independent, separate factor. So do your due diligence, take control of your health to the best of your ability now, and let other people know so that they can do the same. Last few. Thoracic spine manipulation for the management of neck pain. This is something that I've seen before. Uh, really, so I'll say this. A lot of people I've seen through the years actually, when they get the quote unquote courage to see me because of the title of chiropractor, they will seek me because they've heard that I don't have to adjust their neck when it comes to their neck pain or neck condition, which is absolutely true. Um, in my clinic, it is not a hard requirement that A, we adjust anything to begin with, but B, if there's an area of your body that you have concern with, whether it's a legitimate concern or not, it's still your body and we have informed consent. And there's lots of other things that we can do to actually manage a wide swath of your conditions. Um, in fact, I have one particular patient in mind. She came in a couple years ago, basically stating that she loves getting cracked like a glow stick everywhere except her neck. So, are there other things that we can do because she was suffering from, on top of general aches and pains from trying to stay active with a pretty wonky lifestyle and schedule? Um, but periodically that would lead to tension, headaches, and neck pain. So, was there things that? Well, of course, there were things that we can do. The fact that she liked being cracked like a glow stick, I could mention other studies that show this here that, hey, we adjust your uh, mid back. A lot of the times it bleeds into your neck for benefit, which is great. You know, you're this beautifully connected system that we don't always have to hit the exact place you feel pain to actually have benefit. Who knew? Um, but we would then resort to other things, again, that we go through and inform consent to just say, hey, we can do instrument assisted work, we can do hands on work, we can do um, mobilizations. So for her, she actually thoroughly enjoyed the mobilization. And for those of you who don't know mobilizations versus manipulations, really we can think about it being on a five scale, uh, 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 with five being a manipulation where it's high velocity really, really fast trying to get the pop, and everything underneath that being slower, trying to get the joint to end range, but either hold it there, try and let the body relax, or kind of oscillate it a little bit so you're giving these little pulses to coax the joint to relax or move the way you want it. And it reduces the risk of cavitations because some people it's just the sound of the cavitation, and for other people, it just seems to be a more tolerable therapeutic intervention. So we use anything and everything. If you don't want anybody touching your neck at all, fine. If you don't want the high velocity manipulation to try and get all the popping sounds in your neck because you don't like that, you don't have to do that either. There's mobilizations all the way up into that. And this is exactly what that person had, or what my patient a few years ago specifically sought us out for. It's because we do this personalized treatment and we know how to do these things. Um, but this one just gave me an opportunity to tell that story and just really shows that you can get just again all these things are in short term as well since we're talking about manipulations, but you can get short term improvements in neck pain, generalized neck pain from just adjusting the mid back um, tool, right? Next up, lasers. High and low level laser therapy for the treatment of various orthopedic conditions, a systematic review. So there's a lot of treatments out there, and a lot of them are better than others in regards to what patients are getting to help manage their pains, conditions, etc. I've had patients go through prolotherapy, PRP injections, lasers, shock waves, decompression, um, you name it. It's out there, and there's definitely some modalities that are much, much better than others in the sense that they have a lot more robust clinical research backing up their efficacy, which means when you actually pay for it, it's more likely to be doing what it says it's doing. I have personal biases to certain modalities. I'm neutral to others, and I'm quite hardline against some of them. So I don't want to turn this into an hour long lecture, but you know what? Let's just keep it to lasers because I think this will be the best sort of study in front of us. So lasers, they're classified into level, low level. There's grades, all the way up to 4. They have different wattages and joules, how much goes into the system, and each one will try and separate itself based upon, it's pulsing at a certain rate to get it so many joules into the tissue. And what it really comes down to is, um, are they hitting the proper wavelengths mentioned in the study to get to a certain depth and certain beneficial effect for the tissue? Are they hitting enough joules into the area to actually get your body to use the energy or to get the dose enough so that the energy is useful for the condition that you're treating? And, do they do their due diligence in making sure that you don't have any contraindications to it? So, depending on the laser that you have and the lasers that I've used in clinical practice, um, the treatment durations and protocols range vastly, which this study calls out as one of the big issues with laser research is a lot of them are trying to patent and make proprietary their own individual um, device, which means, yeah, the protocol, quote unquote, may work, but oftentimes that study is done with in-house, making it poorly reliable because the people are biased. And then how do you replicate that on another device if they're trying to patent a specific delivery mechanism? So they called that out, but generally speaking, most of the research points that it can treat a lot of musculoskeletal conditions. And let me see if I can pick out a few that are worth mentioning. Um, from almost 60,000 records retrieved, 8 controlled trials met criteria. Diverse conditions that include but are not limited to knee osteoarthritis, chronic low back pain, patellofemoral pain syndrome, plantar fasciitis, subacromial pain impingement, and lateral epicondylalgia. So basically, your let's see, lateral golfer's elbow. But I'm sure you'd see the same thing with tennis elbow. Bum. They said that so far, high level laser therapy was associated with faster improvement, but both work. Ah, so getting back to the protocols that I would use, depending on the power of the laser, you may have somebody underneath what's called a cold laser, so it doesn't generate enough thermal energy to actually heat up the tissue, but you're still getting enough joules from the light into your system for the body to use. But those lasers would often take the patient, upwards of 20, 30 minutes while the laser is working over this area. It's one of those where, you know what, if you have the time, money, and ability to relax, and the person's got the spare room and the device, sweet. You can honestly set it and forget it, and it doesn't require a practitioner to actually use the laser or occupy the laser while you're doing it. So for the right clinic and the right patient, it's great. There's also hot lasers, well, high level lasers, which can also be colder or hot. I've typically in practice, I've more often used the hot lasers. So this is one where you have to have a therapist, assistant, or practitioner making sure that they are gliding the laser over your tissue in a rhythmic pattern so that it doesn't stay on one spot for too long because the energy will build up so much that you're actually going to burn the tissue. Um, Now, again, pros and cons to all models. Obviously, if you're adding a thermal effect the patient feels, they seem to get better quicker. But again, as long as they're getting better and speed's not the name of the game, doesn't matter which one you get. I would still say, though, make sure that you do your due diligence as a patient because don't get me wrong, there is a huge responsibility on the side of the provider to make sure that they're doing the best they can for you. but there are certain things that can put up barriers to that, whether it is the system, whether it's payment methodologies like insurance versus not insurance with different incentives for both. They're going to do, if they're ethical, they'll still do their best, but they can still make a mistake. And then there's also the people that don't care about doing their best and just want to stay afloat, which means it's life in the medical system. It is what it is. So you have to make sure you're doing your due diligence as a patient to make sure that what that provider is telling you not only passes the sniff test, ergo, do you have any bad feelings about what they're saying, but two, don't just jump right into buying whether it's a package deal, signing onto a care plan, etc., for any modality, laser included, before you do your research about do you want to take the time, space, etc., and are you making sure you're doing the legitimate long-term benefits for your health first before you add in the cherry on top? Because I know a lot of patients over the years, whether I was an intern or early practitioner, they would seek this out specifically as their cure. Like, oh, I have this knee pain. I'm coming off of partially tearing my MCL in the knee. So I'm going to go get it lasered and that should do me up just fine. And I'll do very light stuff, light PT at home. Flip it on its head. You need to have progressive PT that is actually challenging to you to get the tissue to adapt, to get everything working for you, and then you can layer laser in there for pain and other symptom management while they're going through it. A lot of people will put these things first as a cure, which again is partially how our medicalized system has operated over the years. Take this pill, you'll be cured. Take this injection, you'll be cured. Take the surgery, you'll be cured. A lot of the responsibility is taken away from the patient. A lot of the ownership of managing their condition is taken away from the patient or given away by the patient. And we are willing, or not necessarily willing, but are more looking for these things that will cure it without changing potentially what got us into that mess in the first place. Um, and again, I also see this when people hit their 40s and 50s, like, it's time for me to make a change. I'm getting older. And, they may hit it hard for 6 months, but, then they'll dip off, return to lifestyle stuffs, and then look for a different cure along the road. Like, um, I've had a few patients that do that over the years where they see me for a bit. And, this could be a discussion on my need to improve my skills as a communicator to get what I'm trying to say across to them in a better manner so that they don't wind up going down this little payment loop, payment trap. But they'll see me for a bit, feel better. They may hit a barrier, or they may want to improve their speed, or they may not have full trust in what I've been doing. So then they'll seek care somewhere else where somebody sells them this package as a cure. Like, oh, if you do this, you should be 100% better. Again, I've seen chiro offices do that, medical doctor offices do that. I've seen a lot of offices overpromise what they are offering. If they want to be a part, awesome. So if they want to say, hey, you're with a rehab chiro or a PT trying to work through this condition and you're having a little extra pain, we can help with that little extra pain, but you got to make sure that this is being used to buy you a window to really hit hard that lifestyle thing that's going to actually last your entire life, especially if you keep up with it. So, welcome to my rant and TED talk about modalities. This one was on lasers. Again, of the ones out there from snake oil to legit, lasers are legit. Do your due diligence, uh, but make sure that it's always paired with lifestyle factors as well. Um, yeah, let's finish it up on something simple. The relationship between rotator cuff disorders and abdominal muscles. Clinical findings in this study, they basically looked at different core muscle sizes, shoulder symptoms. They correlated them together and said, oh, look, if you have rotator cuff pathology on the same side, you have reduced, I think it's external oblique. Yeah, external oblique muscles. So therefore, blah, 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 blah. Cool. Chicken and the egg thing again. Did they happen to have those before, and because they had those, then they developed rotator cuff pathology, or did they develop rotator cuff pathology and then they had their body had a workaround that led to reduced thickness? Who cares? Take a whole body approach. And when it comes to treating patients, if you're seeing a provider, PT, anybody who's doing any sort of rehab exercises to you for a focal local condition, and the only thing they're doing are exercises at that site, they are missing a lot. They're missing the forest for a tree, a sapling, really, because this is an opportunity to build, like, even if you want to take a myopic view of a condition and say, I want everything, every exercise for my knee, you still need to incorporate whole body, multi systems, compound movements for that knee. Because you're not just going to sit there for knee pain and do knee extensions and knee flexions, quad work and hammy work. You got to include different things that actually get the joint moving, grooving, and absorbing load, generating force through different speeds of movement, lengths of movement, depths of movement, which means even if you want to take that, whether you're a practitioner or patient's like, no, only knee stuff, only knee stuff. Well, fine. I'm still going to get you jogging. Well, look, there's cardiovascular health. I'm still going to get you eventually, again, on the tail end, sprinting because you got to be able to generate force through there. Get you cutting and doing change of direction because your knee has to work and disperse forces and balance in between the ankle and hip while you're doing different cutting movements in life. But I'm not an athlete. Yeah, but you're eventually going to hit 65 someday and you're going to have an increased risk of fall and break your hip. Most falls aren't front to back, they're to the side. So if you incorporate change of direction stuff, you can catch yourself, you're falling to the side. So running, jumping, sprinting, change of direction, endurance work, squat work, compound movements. You're still going to do it all, even if you're doing a myopic look for the knee. But if you as a patient only want to do machine knee extension, if you as a provider can't think of more reasons beyond I'm treating the knee, you can still program to get all these benefits. But please, if I'll kind of do it both ways. Doctors, if you're a provider, therapist, coach, whoever's watching this, if you have somebody in pain, by all means, come up with targeted movements, exercises that will actually load that tissue in a tolerable manner to get it to adapt the way we want, and have workarounds for that person to meet the rest of their activity requirements, and program for the whole body, making this just an additional little blip on the radar while you're taking care of them. Patients, if you're going through this condition, be your own advocate in the sense that if somebody I'll bring up this story for patients. If this sounds like you, get another provider fast. I had a work comp gentleman see me 2 years ago. It was after he was seeing a PT group for 6 to 8 months, after he was moving dirt, a lot of dirt, in a wheelbarrow up a ramp to go into a truck to be loaded out. The ramp broke. He fell. We decided really, really bad. And he was, if he's being honest with me, he was essentially doing clamshells and the McGill Big Three for the entirety of that 6 to 8 months, essentially. I'm speechless. In that time, he never progressed. In that time, they didn't consider other tolerable cardiovascular interventions like, hey, fine, you can't lift and load yet because your back's too sensitive, tight, and you're not mentally ready for it. Fine, can you go for a walk? Yes, I can. That's where I started them with. I then added a little bit of loaded walking. Then we started adding targeted things like tolerable bridges, hammy curls. Then we started adding in hold and load isometrics, wall squats. Like, just do more. So patience, if that sounded like you where you're in this little loop, not doing anything more, not progressing in any capacity, your provider's not adding time and or weight and or direction and or difficulty. I'm going to say that in air quotes because that's its own hour-long argument. If they're not programming more things that your body has to be capable of despite your condition, seek another provider. Like I'll end it with this. No matter your condition, whether it is finding a general practitioner for the annual physical just to have a doctor be your primary provider, whether it's seeking a chiro, whether it's seeking a PT, whether it's seeking a surgical consult because you have to eventually go in for surgery, just whatever it is, try to get 2 to 3 consults. Find the right provider for you and for the right condition you're going through. Just settle for the closest, most convenient, most in-network provider because the human condition is so complex. Even if I know I can successfully manage the condition that you're dealing with in front of me, we're not the right fit from a communication standpoint, if we're not a right fit from a location standpoint because you're not going to be comfortable in the environment, no matter what it is, if any of those are the case, then I've made recommendations for other people to see other providers. Do the due diligence. I'm not offended if a patient says, well, I don't know about this. I want to see. Brilliant. Because one of two things is either going to happen. Either they're going to find a better provider for them for the condition, all parties win, or they're going to find another 2 people that they were like, oh, wow, they're really worse than the first me that the first guy that I saw. He did know what he was talking about. That adds more trust and confidence into that person seeking my care. There is no world in which I lose in the scenario, patients seeking additional care or comparing me against other providers. No loss whatsoever. Same thing with your GP. If they're a terrible for your style of communication, how much benefit are you really going to get? If you're a physical therapist, same thing with me, if you find that for you they're a terrible communicator for how you prefer to communicate, if they're not, educating you, if they're not doing these things, seek another provider, another consult. Surgery, again, don't just settle like, oh, I was told I need surgery. This guy's in my network, so I'm going to go. I ask my patients who have to go through surgery, how did you like this specific provider? Like there was a brilliant one for a doc in one of the bigger surgery groups on this side of the cities. And they said, look, the surgery he gave was great, but we do not like how he communicated to us about the condition and the follow-up. So it's like, okay, noted. And they basically said, yep, but he had great front desk staff and other office assistants that basically made up for this provider. So it's like, okay, so if a patient gets sent to this group, and I can't always, control who they're going to get the surgery with, if they get that provider, I can then preempt them and say, hey, look, he's a great provider. Patients in the past have this to say. Take it as you will. If that's something that's a complete turnoff, even if he's a great surgeon, you know, take it for what it's worth. Um, and it enhances care. Find the right person for the right provider for the right treatment for the right condition at the right time, but it requires both providers being ethical and advocating, and it takes patients advocating on their behalf to improve this entire broken medical system. I'm going to keep ranting if I don't get off now, so that's what I'm going to do. Thanks for sticking with me. Until next week.